Hi everyone, my name is S.H. Kim, and in this talk I will discuss the imaging clues of the nutcracker phenomenon and nutcracker syndrome at contrast-enhanced CT and MRI. Nutcracker phenomenon is just a phenomenon of compression of the left renal vein between the aorta and superior mesenteric artery. And if that patient has symptoms or signs related to this phenomenon, we call it a nutcracker syndrome. A 17-year-old man with gross hematuria due to nutcracker syndrome. Early phase contrast-enhanced CT while shows the jetting of contrast-opacified blood flow across the narrow aortomesenteric space, and Doppler ultrasound confirms very high flow velocity of 226 centimeters per second. In 2011, we published an article in European Journal of Radiology reporting those findings of nutcracker syndrome as CT. This is a big sign, and this is a narrow aortomesenteric angle described in this article. This is another article we published recently, and we found that there are 4 patterns of contrast opacified left renal vein flow. First, a plug flow that is a definitely normal flow, and the last is a jetting pattern that is definitely abnormal flow, indicating nutcracker phenomenon. 2 more patterns exist regarding flow of heavier contrast opacified blood. One is along the dependent posterior margin of the left renal vein and inferior vena cava, indicating slow flow, and the other is along the non-dependent anterior margin, indicating faster flow. This pattern 1 and 2 indicate slow flow, and so absent nutcracker phenomenon, while this pattern 3 and 4 indicate faster flow and suggest the presence of nutcracker phenomenon. This is a 40-year-old man with microscopic hematuria, and the flow pattern in this patient is type 3 along the anterior non-dependent margin, and this CT finding suggests nutcracker phenomenon. This is an asymptomatic man with a normal plug flow pattern of the left renal vein without the compression. Another asymptomatic man, in this patient, the space between the aorta and superior mesenteric artery is slightly narrow, but contrast opacified blood flow along the dependent posterior margin of the inferior vena cava, suggesting slow flow, so absent nutcracker. A 23-year-old man with gross hematuria due to nutcracker syndrome. Cystoscopy showed gross hematuria from the left urethral orifice, and contrast-enhanced CT in early arterial phase show flow of contrast opacified blood along the anterior non-dependent margin of the left renal vein and inferior vena cava, indicating fast flow, so nutcracker positive. A 16-year-old man with microscopic hematuria for 3 years due to nutcracker syndrome. The CT shows compression of the left renal vein between the aorta and superior mesenteric artery with jetting of contrast opacified blood flow along the anterior non-dependent margin of the left renal vein and the vena cava. And color Doppler ultrasound shows bright colored jetting along the anterior margin, and peak flow velocity was 261, a very fast flow. Another case, 48-year-old woman with uterine cervical carcinoma. CT images show narrowing have the aortomesenteric left renal vein and the contrast opacified flow along the anterior margin and the dilated collateral vessels is in the renal hilar area. All these findings indicate the presence of nutcracker phenomenon. Recently, we have done a study in patients with bladder cancer who underwent radical cystectomy and neobladder formation. After surgery, these patients are usually followed up with regular CT examinations and regular urine analysis. If those patients show persistent microscopic hematuria, patients and physicians, both sides, worry about the possibility of tumor recurrence, and in those cases, CT findings are very important. Usually, kidneys, pelvic-calyces, and ureters are closely evaluated for tumor recurrence, but the prevalence of upper tract tumor recurrence is not very high, at maximum about 5% in 5 years, and tumor recurrence at neobladder is extremely rare. Because I have a strong belief that the prevalence of nutcracker phenomenon is high, I thought many of those cases with persistent microscopic hematuria may have nutcracker phenomenon, and so we decided to have a study to check it out. We performed a study in 135 patients who underwent radical cystectomy and ileal neobladder formation, and the CT findings were evaluated and were correlated with the incidence of microscopic hematuria in urinalysis examination. There were negative CT findings for nutcracker, like a plug flow pattern or flow of contrast opacified blood along the dependent posterior margin in 92 patients, while there were positive CT findings for nutcracker like contrast opacified flow along the anterior margin or jetting in 43 patients, in 32%. This prevalence of positive nutcracker findings at CT 32% is very equivalent to the 30.4% in our previous study using a Doppler ultrasound. We divided hematuria incidence among urinalysis examinations in 4 categories: no hematuria at all, 1 to 49%, 50 to 79%, and more than 80% incidence of hematuria at urinalysis examinations. There were 4% of the patients with negative CT findings of nutcracker showed category 3 persistent hematuria, while the persistent hematuria was seen in 12% of patients with positive CT findings. Hematuria was absent only in 2% of the patients with positive CT findings, while hematuria was absent in 23% of the patients with negative CT findings. This difference was statistically significant. Therefore, as we expected, when we are evaluating follow-up CT images of the post-operative bladder cancer patients, we need to evaluate the flow patterns of contrast opacified left renal vein flow at early phase CT. And if a patient with microscopic hematuria shows CT findings of nutcracker, then we do not need to worry too much about tumor recurrence, because the hematuria in this patient is probably due to nutcracker phenomenon. As I mentioned in the Doppler ultrasound talk, there are 3 types of nutcracker phenomenon. Type 1, compression of left renal vein between the aorta and superior mesenteric artery. Type 2, compression of the left renal vein posteriorly by the right renal artery, and type 3 left renal vein is stretched over the abdominal aorta. A 62-year-old woman with left flank pain and bladder symptoms due to nutcracker syndrome. CT shows compression of the left renal vein between the aorta and superior mesenteric artery, and also left renal vein is compressed by the right renal artery here. So combined type 1 and type 2 nutcrackers in this patient. These CT findings are same as we see in ultrasound findings. However, we do not have flow velocity information with CT. In this young woman with hematuria, proteinuria, and hypertension, CT shows this pattern of left renal vein stretching over the abdominal aorta and jetting of contrast opacified blood along the anterior margin of the left renal vein and inferior vena cava. Nutcracker can be associated with congenital variations of the left renal vein and the inferior vena cava, and CT scans well shows these findings. Embryogenesis of the left renal vein starts from these yellow-colored paired posterior cardinal veins in the 4th week of embryogenesis, and it is formed by appearance, persistence, fusion, and disappearance of the subsequent pink-colored subcardinal veins and blue-colored supracardinal veins. In the 5th week, the pink-colored subcardinal veins develop anterior and medial to the yellow-colored posterior cardinal veins and drain, developing mesonephros. In the 6th week, the blue-colored supracardinal veins develop posteriorly and drain bodyward through intercostal veins. Normally, suprarenal inferior vena cava is formed from the subcardinal vein, while infrarenal inferior vena cava is from the right supracardinal vein, and the left renal vein is formed from the intersubcardinal anastomosis. The most common variation is retroaortic left renal vein, which is the result of the persistence of the posterior retroaortic arm of the venous ring and obliteration of the normal anterior preaortic arm. Often, nutcracker phenomenon is accompanied by retroaortic left renal vein, and this nutcracker is called posterior nutcracker. Another patient with a posterior nutcracker, 49-year-old woman with microscopic hematuria and proteinuria, and CT images show severely narrowed retroaortic left renal vein between the aorta and the vertebra and jetting of contrast opacified flow. And Doppler ultrasound also shows retroaortic left renal vein with high velocity flow here, and peak flow velocity was 94.8 centimeter per second. Another variations associated with nutcracker phenomenon is left-sided inferior vena cava. An 18-year-old man with gross hematuria, and cystoscopy showed hematuria from the left urethral orifice, and coronal CT images shows left-sided inferior vena cava that receives contrast opacified blood from the left kidney and continues to the right side suprarenal vena cava. Anatomically, left renal vein is not narrow, but blood from the left kidney should compete with the large amount of blood from the left side inferior vena cava, causing functional or hemodynamic nutcracker phenomenon. And the spectral Doppler confirms nutcracker phenomenon with a peak flow velocity 182 centimeter per second. A similar functional nutcracker phenomenon may occur in a patient with double inferior vena cava, And this is an example in a 13-year-old boy with gross hematuria. The CT image shows double vena cava, and spectral Doppler ultrasound shows peak flow velocity 112.4 centimeter per second. Another example of double infib vena cava with functional nutcracker in a 58-year-old woman with microscopic hematuria receive bilateral inferior vena cava, and we clearly see the flow of contrast opacified blood from the left kidney together with non-opacified blood from the left side of the vena cava, and the nutcracker phenomenon is confirmed with spectral Doppler ultrasound with a peak flow velocity of 166 centimeter per second. One thing I want to mention is that frequently the nutcracker findings at CT and the findings at ultrasound look quite different. CT shows just a subtle compression of the left renal vein between the aorta and superior mesenteric artery, and we may not suspect nutcracker with the CT in this patient, but color Doppler well shows compressed left renal vein between the aorta and the SMA, and bright colored jetting phenomenon with a peak flow velocity of 137 centimeter per second. Probably this difference between CT and ultrasound findings is related to the difference in respiration status. These CT findings, CT images were taken with the patient in inspiration status, and these Doppler ultrasound images were taken in the expiration status. MRI is not the primary imaging modality to detect nutcracker, but may give us useful information regarding hemodynamic changes of the left renal vein. Normally, a T2-weighted MRI left renal vein appears dark, signal void structure, but if the flow of the hilar left renal vein areas becomes stagnant due to compression at aortomesenteric portion, it may show high signal intensities. This is an example. 46-year-old woman with microscopic hematuria and T2-weighted MRI shows high signal intensity in the hilar left renal vein up to the narrow aortomesenteric portion, and this is her venogram showing compressed the aortomesenteric left renal vein and the paravertebral collateral vessels. Another example, 35-year-old man who had persistent microscopic hematuria at the right partial nephrectomy for venous carcinoma, and CT shows compression of the left renal vein by the right renal artery and flow of contrast opacified blood along the anterior margin of the left renal vein and vena cava, so type 2 nutcracker. And this is his T2-weighted MRI image, and it shows high signal intensity in the left renal vein up to the site where left renal vein is compressed by the right renal artery. So when you see MRI images of the abdomen, please look at the signal intensity of the left renal vein. If you find this kind of high signal intensity in the hilar left renal vein, then please look at the patient's urinalysis report for microscopic hematuria or proteinuria. And if the patient has hematuria or proteinuria of unknown origin, then please include these findings in your interpretation for the patient's microscopic hematuria or proteinuria in your reading report. Your report, including those information, may be very helpful to your referring physician and the patient. This is the conclusion. When you see CT or MR images of the abdomen, please do not skip the left renal vein. you may find useful clues indicating nutcracker, and you may help the patient and the referring physicians. Thank you for joining this talk, and if you have any questions or comments, please email me.